Good morning, everyone. Welcome again to this month's NCAS Journal Club. Again, we have two excellent talks. Our first one is from Stephen Tong, who is a infectious diseases doctor here at the Doherty Institute in BIDS. Has been working with the Hot North group up in Northern Territory, Queensland and WA, and he's here to talk about some results of some of the research we have done into the Indigenous antimicrobial prescribing up there. Thank you, Stephen.
That's right. Thanks everyone. Thanks for the opportunity to talk a bit about this work. And it really kind of, I think, stems from
And now you can use it.
Okay, sure. A recent perspective article that we published in the Medical Journal of Australia, which really was almost like a call to arms about the need for antimicrobial stewardship in the rural and remote primary health care sector. So before I go further, let me acknowledge the traditional custodians of the land that we're on at the moment, the Wurundjeri people of the Kulin Nations, and pay my respects to elders past, present and emerging. So this, I guess, perspective article, you can see the authors there, but really it was a much broader group that contributed to that. So it included, and I'll go through this in more detail later, but included people in the primary healthcare and I guess antimicrobial stewardship sectors from Northern Australia, so the top end, Kimberley and Queensland Health, as well as people representing NCAS here. So briefly, the overview of my talk will be looking at rising rates of MRSA in remote areas, thinking about what are the drivers of this increasing antimicrobial resistance, the context of antimicrobial use in those areas, and a pilot project that was funded by Hot North. So here's just a, I guess, pictorial representation of what's happened with MRSA rates in the Northern Territory. So this is 20 years worth of data from a pathology provider that looked after all the communities in the top end and the rest of the Northern Territory. So this is not hospital-based data, but this is really community-based data. You can see that over these last 20 years, really rates of MRSA have increased from less than 5% up to around 25% by 2012. And the size of those circles is representative of how many samples there were in each of those years. So quite a, I guess, just continuing increase in MRSA over those 20 years. And more recently, the rates have been even higher. So a couple of more recent publications showing that at the Alice Springs Hospital, amongst skin and soft tissue infections requiring incision and drainage in hospital, 60% of those were MRSA. And it really meant that at a population level, about 1% of the drainage population of Alice Springs Hospital were presenting to the hospital with a need for incision and drainage due to staphylococcal skin and soft tissue infections. At Tennant Creek Health Centre, 46% of staph isolates were MRSA. Again, at a population incidence of 13% of the population was presenting to the clinic with a staphylococcal skin and soft tissue infection. So ongoing, very high rates of MRSA. What's happening in WA? Well, WA has been amazing in that MRSA has been a notifiable, I guess, condition in WA for at least the last 20 years. And so they've probably, of anywhere in the world perhaps, have got the best figures on numbers of MRSA isolations over time. And you can see that the rates have just continued to increase and the colours represent the different clones. And there's two particular community-associated clones, ST93 and ST5, which have really risen to prominence. And when we again look at a population incidence in the Kimberley region, this means that 1 in 25, so 4% of people every year are having MRSA isolated and needing to present to a clinic for those isolations over the course of a year. So very, very high burden of disease. And what's happening in far north Queensland? So this is again recent data of about 20 years and the map is coloured according to the rates of the MRSA or prevalence of that over time. And you can see that there's really a gradual increase in redness and in many areas in far north Queensland now, we're sitting around that 40 to 50% rates of MRSA. Teresa Wozniak and others are trying to put all this data together now, and they've created this, web site called Hotspots, which really is trying to put this data together in a mapping manner, so that local providers can get onto hotspots and say, well, I'm working in the Kimberley, or I'm working in the Pilbara at the moment. What are the rates of MRSA most recently in my jurisdiction? So you can actually log on to that website there and play around with that data. So it's not just for Staph aureus, but they've also got data for E. coli, K. pneumo, and other organisms as well. But again, you can see pretty much across the north there, and the scale's a bit different from those previous ones. There were a lot in that kind of light green, yellowish colours, indicating heading towards 40–50% rates of MRSA. So I think it's important to note that I've just talked about MRSA, and that resistance is not uniform across other organisms. So here's Neisseria gonorrhea and E. coli from the AURA report. And for gonorrhea, the Northern Territory, remote resistance rates are actually much lower than anywhere else in the country. And in fact, the local guidelines recommendations suggest that you can use amoxicillin to treat Neisseria gonorrhea in a remote setting. Similarly, with E. coli and K. pneumo and third-generation cephalosporin resistance, the rates aren't higher and perhaps are a little bit lower in the Northern Territory compared to elsewhere in the country. But certainly for MRSA, it is much higher. So again, these are data from the AURA report. On the left is the percentage of MRSA by remoteness area. You can see in the major cities, it sits around 20% and consistently for the last 3 years. But in the remote and very remote areas, again, similar to the figures I've shown before, it sits around 40%, so approximately double. And if you look at the blood culture isolates of Staph aureus by territory and state, the Northern Territory clearly stands out as an area with rates over 40%, and most of those are that darker colour due to the community-associated MRSA strains. So I guess the question is why is this the case? Why have we got such higher rates in the Northern Territory and in remote areas particularly for MRSA? So three things that I can think of is that there's a large burden of disease, there's a resultingly large burden of antimicrobial use, and factored in is also the social determinants of health. So heavy burden of disease, of particularly I think skin infections, respiratory tract infections, and otitis media as three, particularly outstanding conditions. With skin infections, we're talking about things like impetigo, scabies, and secondarily infected scabies, and also, abscesses and furuncles. So here's also some data from quite a while ago now, but by the age of 12 months in many communities, about 70% of kids, if you follow this black line, were presented to the community clinic with a skin infection requiring clinic management. When we look across the board, including in adults, about 75% of adults will present to a community clinic every year with a skin and soft tissue infection that needs management. In terms of respiratory infections, there's a 43% incidence of hospitalisation in the first year of life for an acute lower respiratory tract infection. So really, really high rates there. And in terms of otitis media, so the WHO actually considers a prevalence of 4% in the population of chronic otitis media as a massive public health problem. And when you look at Northern Territory data, about 90% of Aboriginal children in remote areas have some form of otitis media. And that's got, massive downstream implications in terms of education and being able to hear and all those kinds of things, but incredibly high rates. And when there's such high rates of infections and the severity of infections, there's the need to use antibiotics to treat these. So this is some data that we've looked at and recently published. About 95% of kids by the age of 1 will have had at least one course of antibiotics during the course of that first year of life. And that compares to about 20% in urban Melbourne. Perhaps even more strikingly, 47% of kids will have at least 6 courses of antibiotics during the first year of life. So we're looking at really high rates of antibiotic use. I suspect it's often appropriate use. due to the number of infections and the severity of infections. Then there's the social determinants. We know that household and domestic crowding is common. So this is again some data we looked at, collected by the Aboriginal birth cohort study. We've been following about 600 Aboriginal kids from their birth in 1987 to 1990 for, 25, 30 years now. And at their last follow-up at the age of about 25, they went to each of these individuals and just asked them, who slept in your house last night, using that kind of whiteboard with the magnets. And when we looked at that data, you can see that there were many households, the majority were more than 5 people per household, and lots in that kind of 10 to 15 range. And many of these households probably have 3 or 4 bedrooms. So when you've got 10, 15 people living in a house with 3 or 4 bedrooms, that means that each room has 4 or 5 people in it. So any infectious disease, it's not just skin or respiratory infections, but any infectious disease that requires some degree of contact is much more likely to spread in such households. There's also other social determinants, so poverty, poor education, poor health literacy, lack of what we call health hardware. So if you've got houses which don't have washing machines, it's very hard, of course, to then maintain personal hygiene within that household, or if half of your showers don't work. You can also imagine having 20 people in a household, having a washing machine, but humidity that's 90% for most of the year. It's pretty hard to wash and get through all the sheets and clothes and get all those dry. We struggle as it is with 3 kids and the weather in Melbourne. So very difficult because of all those kinds of things. It's interesting that there's probably, I guess, some emerging thinking that antimicrobial resistance is not just related to antimicrobial use, and that there's lots of other factors that come into play. So this was published, I think, earlier last year, led by Peter Collignon, showing that resistance, antimicrobial resistance, is perhaps even more related to markers of corruption and poor governance in countries, as well as poor infrastructure and sanitation. So it's not just about antimicrobial use. So in fact, they found in their multivariate analysis that antibiotic consumption was not significantly associated with either antimicrobial resistance index in the multivariable analysis. And so they call this contagion, that sure, you need antibiotics to be used to drive resistance, but for that to then spread requires a poor infrastructure, poor governance and corruption and so on in the countries, and a strong correlation between those kinds of factors. And interestingly, there's been some work on climate as well. So here are 2 maps of the US. The one on the left is resistance rates of E. coli, and on the right is a temperature map. And you can see that there's, just visually, it's a pretty striking correlation. And when they do the statistics, which is on the bottom left there, with the minimum temperature and then antibiotic resistance rates, amoxicillin on the y-axis, there's a pretty reasonable correlation between those. So that's in the US, and their temperatures on that bar go from 0 to 20. That's the temperatures in Darwin for the year. Red, the maximum temperature, blue, the minimum temperature. So it's pretty hot there, and you wonder whether that has, if this correlation is true, how much of an impact the actual environmental factors have towards driving antimicrobial resistance in these tropical regions.
Steve, how do you, because you had the gram-negative figures on E. coli and so forth, actually being quite low. How does that sort of map into the story?
Yeah, look, I don't know exactly. So obviously this kind of work hasn't been done in Australia. It'd be interesting to see. Yeah, it's a good point. And certainly they've shown a similar thing with MRSA as well in the US. So they've concentrated on E. coli with this map, but they've done something similar with the MRSA. But it's a good point. I'm not entirely sure.
They observed with salmonella chicken.
Right, okay. Yeah. So, I mean, their postulated mechanisms are things like that bacteria replicate more quickly when it's hotter, and that it also facilitates horizontal gene transfer, that's more likely to occur. And that's all kind of theoretical. And this is all an ecological association, so it's not necessarily causative. Yeah, but it's a good point that is kind of the other way around. Yeah. So how are medicines prescribed or administered in Aboriginal health services? Well, there's this thing called S100 dispensing under the PBS. So this is for health services to be eligible for this S100 dispensing. The health service needs to be for Aboriginal and Torres Strait Islander peoples. It needs to be a health service in a remote zone. The supplied medications needs to be under the direction of qualified persons. So usually that's medically qualified doctors. The clinic needs to have appropriate storage facilities. And this means that you don't need a doctor to do the administering of the antibiotics. So there's orders that say an Aboriginal health practitioner or a remote area nurse typically can administer antibiotics or other pharmaceutical benefits. And this is provided free of charge to the patients. So that's just from the PBS website of the total expenditure for medicines across the different states and territories. You can see that really the major use of this S100 scheme is the Northern Territory, but quite a lot in Queensland and WA as well. So we're looking at 1.6 million PBS items supplied through this to a cost of about $40 million. So this means that when there's guidelines such as this for, say, impetigo in these regional guidelines, that the remote area nurse or the Aboriginal health practitioner can read the guidelines, make the diagnosis and administer the medication, be it in this case benzodiazepine penicillin or trimethoprim sulfamethoxazole at those doses. And so there's each of these regions that we worked with have these quite specific guidelines. So the CARPA manual in the Northern Territory, there's Kimberley guidelines and also the Primary Clinical Care Manual in Far North Queensland. So moving on to a pilot study that we did, we were aiming to adapt and apply the NAPS survey to the setting of Aboriginal medical services in Far North Queensland, Northern Territory and the Kimberley. We audited a total of 530 episodes of care when antimicrobial was prescribed. So basically we chose 5 clinics and in each jurisdiction, so that's 15 clinics in total. And we looked through the records until there were 30 prescriptions for antimicrobials. And this was done by local providers in each of these jurisdictions. So the audits were conducted at various times between August 2017 and June 2018. 88% of the patients were Indigenous. So who and for what? So the prescriptions were done really by a mix of doctors and remote area nurses. I think there were, of all those 530 episodes, there were only 4 in which Aboriginal health practitioners administered the antibiotics. You can see the breakdown between WA, NT and Far North Queensland. So across the kind of, I guess, the horizontal axis is the proportion of antibiotics administered by doctors and nurses in each of those jurisdictions. And then on the y-axis is the syndrome for which the prescriptions were provided. So if you take as an example here, in WA, there were 38 prescriptions for skin and soft tissue infections provided by doctors and 42 provided by nurses in that setting. And if you just have a look at the colours, you can see that skin and soft tissue infections in orange form a kind of large component. Lower respiratory tract infections are the purple, so there and there. Gastrointestinal, so that was often deworming, so albendazole. And then sexually transmitted infections in green formed quite a large number as well. So that gives you a sense of what conditions were commonly for which antimicrobials were commonly prescribed and who was doing that prescribing. Or really not so much prescribing, administration, I suppose. And then what were the actual antimicrobials that were used? I've provided on the left what we saw in our audit and on the right what was seen in a publication amongst urban GP practices. So maybe if we'll just start with urban GP practices, cefalexin, amoxiclav, roxithromycin, doxy, clarithromycin, trimethoprim were the top 6, but quite different in these remote clinics. So benzodiazepine penicillin was the most commonly used antibiotic, followed by amoxicillin, cotrimoxazole, bendazole, and amoxiclav. So we were in some ways, I guess, maybe surprised or maybe not surprised, but that the narrow spectrum antibiotics tended to be used quite frequently in these remote clinics, which is quite different from what we saw in urban Melbourne GP clinics. So this also reflects, I guess, the burden of disease. So benzathine, penicillin and Bactrim are commonly used for skin and soft tissue infections, and amoxicillin for the lower respiratory tract infections. How appropriate were these prescriptions? Well, about 80% were considered appropriate, which actually I think is pretty good. I'm not sure, I can't remember what the GP NAPs and hospital NAPs kind of appropriate rates are. Kaz, is it kind of around 80%? Okay, so...
Means appropriateness is 80%, but TG appropriateness is quite low.
Okay, yeah.
So we identified that other GPs have been given to means because that's what's invented.
Right, yeah.
But also, yeah, and I don't know whether you probably had a reasonable idea of indication that they're all set. Right?
At times, I mean, it was difficult to sometimes get that as well, so people had to actually manually go to records and read what the notes said.
That's
yeah. So it was actually quite time consuming.
That's higher than the hospital NAPs, for example, which sits around 72.
Okay, yeah. So this could be a good news story that comes out of this. And I think that partly relates to, one, that there are fairly prescriptive local guidelines. And secondly, for a remote area nurse or Aboriginal health practitioner to administer antibiotics, they have to go by those guidelines. So most of the inappropriate ones are either, doctors doing that, or the dosing at times or timing being incorrect. It was interesting in Queensland, you see that it seems like there's a larger proportion which are inappropriate, but a lot of that was actually related to cotrimoxazole use, which hadn't necessarily entered into the local guidelines yet for skin and soft tissue infections, but a lot of practitioners were beginning to use that based on some more recent clinical trials, which therefore probably were appropriate in the setting where there's high rates of MRSA and susceptibility to cotrimoxazole, but they hadn't actually entered into the guidelines. And I think partly because of that, some of the dosing and timing varied as well in what people actually prescribed or used.
Just on the comment of that, because you can actually look at guideline compliance and appropriateness, so you know, might be non-guideline compliance still appropriate.
Yeah. So we did include that in terms of that appropriateness thinking, and the appropriateness. Therefore, Bactrim was often said, yes, that's appropriate, but the dosing wasn't consistent and there were issues with that. So I'm just going to summarise now that I think antimicrobial resistance and stewardship in regional and remote areas is really quite different and will require different models and different ways of thinking. So high rates of AMR, particularly for skin and soft tissue infections, this relates to this very high burden of infections. And I think to address rising rates of antimicrobial resistance will actually require trying to reduce the number of infections and the prevalence of infections. And that then involves addressing the social determinants of health as well, which is a massive thing, right? And not something I think we can just, it's not easy to just build more houses or better houses, that kind of thing. But I think we can advocate for improving social determinants, just as other areas of the health sector will do that. I think that's a role that we can play as well. And I think we need to recognise that antimicrobial use is different. The spectrum of infections is different, and therefore what antimicrobials are used will be quite different in the remote setting as well. What are some next steps? Well, one of the things that, as we wrote this perspective piece for the MJA, we tried really hard to engage with Aboriginal health practitioners, Aboriginal doctors, Aboriginal primary care sector to say, hey, look, can someone join us in writing this piece? And we found it really hard to find one or two or, people to engage with us on this. I think it's just that this AMR and AMS is not really on the agenda for Aboriginal health at the moment. So it's going to be critical for us to try and build that capacity and build that Indigenous voice, because it's all very well for people like me from the southern states to be talking about this. But what it really needs is Aboriginal people to be talking about this and to see this as an issue, if they do think it's an issue. So amongst all the competing health priorities, they may actually say, no, alcohol, mental health, or kidney disease is much more important than AMR and AMS. But I think we need to build some capacity there for them to make those prioritizations instead of us saying that, this is what you should be doing. There will require, there still will be a need for AMR and AMS surveillance to occur in remote areas. We need to refine these tools. So, our adoption of NAPS, it was very time consuming and difficult to use as an audit tool. So we need to refine those. I think we need to then fit that into this continuous quality improvement framework where there's ongoing feedback back to communities and clinics about rates of resistance, but also their use of antimicrobials to say, yep, you're doing a great job, or no, here's some areas that you can improve. And those kinds of frameworks already exist in many Aboriginal health services for things like hypertension. So there's no reason why we couldn't use that framework for AMR and AMS. I think there needs to be more coordination of this across those jurisdictions as well. So there are some AMS services in, say, the Northern Territory or the Kimberley regions, but they're not terribly well coordinated, at least in that primary healthcare sector. Sure, there's some happening in the hospitals, but not really in primary healthcare. And as I've mentioned before, we can have a role in advocacy for improving social determinants of health. So lots of thank yous. I've listed people here from the Kimberley Aboriginal Medical Services, the Top End Health Service and Queensland Health, who are really the local partners in this pilot project. Will Cunningham at the Menzies School of Health Research, whose PhD is broadly in this area. NCAS, Kirsty and Rod have been critical in helping us to frame this work. And then Asher Bowen at Telethon Kids and Jodie McVernon, who really led the study from the Doherty. And thanks also to Hop North, which is based at the Menzies for a pilot grant to do this piece of work. Thank you.
Steve, your comments around awareness, it's not just what's happening out there either. I think we call it the zombie issue.
Yeah.
Actually, it seems to get any traction. And that's a piece of work that has to be done. But I don't have a strong solution because we don't actually have a funded awareness program in Australia.
Yeah. I reckon nowadays that people, my sense is that you go to a GP, people aren't necessarily always wanting antibiotics now. There's a greater awareness that, hey, I've got a sore throat or my kid's got a sore ear. If I can avoid getting antibiotics, I'd probably prefer that. Do you think that's the case, or is that just me in my kind of... Yeah.
But, they're about to... So there are some drop nudges that are going to happen. So I was actually wondering about that because of the distance of how to travel and complexities getting to medical care. If the PBS comes in and says you can't have restriction, can't have repeats for X, Y, Z antibiotics, that would be an issue, wouldn't it? For some,
yeah.
Access to antibiotics is a flip side of the point to over-access.
Yeah. So the actual, in some ways, the access to healthcare isn't that hard for community-based people. So there's almost always a community health clinic, and everyone's within a kilometre or 2 kilometres of that, so you can get there. It's actually more working out whether someone's sick enough that they need retrieval back into the tertiary centre, and there's probably therefore a lower threshold for use of antibiotics because you don't want that person to get sick enough that they need to then catch a plane in.
And it is a really good news story because to see that they are actually using narrow spectrum antimicrobials with much worse infections that we have in metropolitan area, I reckon that is something that really should actually be highlighted.
I think that's a really good point. Actually. Yes.
Because why are we throwing that calculates in the There's just zero reason. Yeah. So that's a very powerful message that comes with.
That's a very good point. We'll make sure we make that point in the manuscript. Yeah. Any other questions from anyone online?
Steve, are there any patient outcome data with the infections, like how how do the patients do after they've been treated?
Yeah, that's a good point. We haven't followed that in our pilot. We know that rates of sepsis are much higher, again, in Aboriginal populations. So I think 4 times the rate requiring hospital admission. And similarly with staph bacteremia, it's 6 times higher in the Northern Territory in Aboriginal versus non-Aboriginal populations. I think that probably relates just to the burden of disease, that if you have lots and lots of simple skin and soft tissue infections, a certain proportion of those will get into the bloodstream. So it actually relates just more to that. Your tip of the iceberg is the invasive infections, sepsis requiring hospitalisation, but that means that there's a much larger pool of infections underlying that. So it's not necessarily that I think the treatments are worse, leading to worse outcomes. I think it's just burden of disease. All right, thank you.
Thanks, Stephen. Our next speaker is one of our PhD fellows, Leslie Dowson, who is also from Monash Health, and she'll be talking about optimising antimicrobial use in aged care homes.
Thank you, everyone. Yes, as Rod said, I will be discussing my PhD work on antimicrobial use in aged care home. So we know that antimicrobials are misused in Australian aged care homes. We have data from the Aged Care National Antimicrobial Prescribing Survey now, and this is from 2016-2017. About 50% of prescriptions are for residents with no signs or symptoms of infection the week prior to the start date. And then when we drill down a bit further and compare those to the McGear criteria, which is a validated in long-term care infection surveillance criteria, we are looking at towards 80% of those prescriptions are being given to people who actually don't have those validated signs and symptoms. Probably don't need to tell this audience about how antimicrobial misuse is harmful to public health and to residents. Particularly in recent years, who've really, there's been a lot of research around how aged care homes are actually can act as reservoirs and gateways for multi-drug resistance organisms into healthcare networks and also into the community. And also there's been some really good work that actually shows that residents who reside in these high antimicrobial use aged care homes are in direct harm because of the antimicrobial use, either for things like C. difficile or other medication adverse events. AMS, the ongoing effort by the organization to optimize antimicrobial use in order to improve patient outcomes, ensure cost-effective therapy, and reduce those adverse events of antimicrobial use. In aged care homes, there are multiple factors which actually contribute to the misuse of antimicrobials, including the health system and care provider factors. Aged care homes are relatively low resource organizations. There are issues with identifying signs and symptoms of infection in residents. They often residents can have atypical or vague signs and symptoms of infections, and also some work around advanced care directives and next of kin factors, which I did touch on in my PhD, and we'll get to. So the aim of my PhD was to optimize the use of antimicrobials in aged care homes. Specifically, we looked at some UTI prescribing in concordance to national guidelines. We implemented an evidence-based microbiological investigation for respiratory tract infections to support optimal prescribing. And then we did attempt to identify a feasible AMS intervention for care near the end of life. This is the outline of my thesis, and I will touch on all 5 of those experimental chapters today. I'll spend more of my time on chapter 5, which is the last project in chronological order that I finished, which is about analyzing antimicrobial use, and again, that nurse-initiated PCR testing. So just briefly on the UTI prescribing, as part of my work, I did do some interviews, and there are some really great quotes that I have which actually highlight all of these projects. And this one is cefalexin, because it can treat a UTI, it can treat pneumonia, it can treat cellulitis. It's a great one to give. You can put on if you're not sure. It's an easy one to give. So it's really interesting coming after the last speaker. So the ACNAB's data is actually swayed towards metropolitan and interregional health aged care homes in the state of Victoria, and I think that's an important point to make. So they're more represented in the survey than their actual representation in the Australian population. But they've been collecting data since 2015 as part of the Australian Commission on Safety and Quality Healthcare Antimicrobial Use and Resistance in Australia project. And we sought out to compare the prescribing for UTIs with the recommendations that were current at the time in the therapeutic guidelines. It was a cross-sectional study, and after data cleaning, we had 662 prescriptions from 247 unique aged care homes. 18 different antibiotics were selected by prescriber, and over 50% of those were prescribed for longer than 6 months, which even for prophylaxis, the recommendation in the therapeutic guidelines is up to 6 months in most cases. The majority of prescriptions were for cystitis, and cefalexin was that most frequently selected antibiotic for treatment. Less than 11% of those prescriptions were concordant with what the recommendations were in the therapeutic guidelines. And overwhelmingly, what we found was that additional daily doses of that 500 milligrams of cefalexin occurred in nearly 65% of prescriptions. So instead of prescribing the twice daily recommendation that were in the guidelines, and I should also say that was the recommendation in the resource, but which was the medicine handbook, which is put out by or recommended by the Australian College of General Practitioners. It is for twice daily 500 milligrams of cefalexin. But what we found was that more often not, they were getting 3 times daily or 4 times daily. So the conclusion is that those AMS activities targeting the prophylaxis for durations longer than 6 months and those excessive daily doses of cefalexin to treat cystitis are required. It would be a really interesting project to redo this after maybe the 2020 collection of the ACNABs, because they have since updated the therapeutic guidelines recommendations. Second up, we implemented evidence-based microbiological investigations to support optimal antimicrobial prescribing for respiratory tract infections. And I guess the quote here is, "I certainly have treated on suspicion without having the evidence." So we attempted to give the aged care home staff and the GPs the evidence as to what actually was happening with respiratory tract infections, see if we could get some movement in their antibiotic prescribing. This was the first study that was published out of my PhD, and it actually, I think, became published officially, I think last week or the week before, in the American Journal of Infection Control. With respiratory tract infections, they are one of the they're part of the big 3, which is skin, soft tissue, urinary tract infections, and respiratory tract infections, which are common in aged care homes. And again, from that ACNABS data, we are looking about 70% actually don't meet the 70% of residents who are prescribed antibiotic for lower respiratory tract infections actually don't have the signs and symptoms of lower respiratory tract infection, so they most likely have an upper respiratory tract infection, of which an antibiotic as an antibacterial usually isn't necessary. In addition to that, up to 36% of community-acquired lower RTIs in older people could be viral. So again, prescribing an antibiotic as in an antibacterial for someone with a viral infection likely isn't going to help. In addition to this, the therapeutic guidelines do recommend the rapid specific microbiological test on nose and throat specimens for the assessment of pneumonia in residents of aged care homes and in the presence of influenza-like illness. For our project, what we did was that we implemented a process whereby the nurses would do the swabbing and collect the specimens. And the reason we did this and targeted the nurses was for several reasons. One being that primary GPs often only visit aged care home 1 day a week on a dedicated day. So if the GP comes in on a Monday afternoon, you're not going to see that primary GP again until the following Monday afternoon. And if a resident gets sick on a Tuesday morning, there can be delays in taking the swabs. In addition to that, aged care homes often have infection registers where they record any active infections that are happened in the home or occurring in the home at any one time. And it's actually the job of the nursing staff to fill in that infection register and also to overlook it. So we taught the nurses to identify respiratory tract infections and to take the swabs. And we're trying to describe these influence of these standing orders for nurse-initiated respiratory PCR testing on residents with new onset respiratory symptoms. It was a pragmatic prospective observation cohort study, and we were looking at what the prescribers did in response to this testing. The nurses received training and recognition of the respiratory tract infection and the specimen collection, and the GPs were to be informed when a specimen collected and a result was reported. 7 homes took part, 4 that were affiliated with Health Service A and 3 that were affiliated with Health Service B. In total, there was 318 beds, and these were all done in metropolitan areas or surrounding areas of Melbourne. Standing orders were introduced for the specimen collection and the testing, and the data regarding the results, the prescribing and clinical review were collected from the medical records by myself. Because it was a pragmatic trial, we were a bit beholden to what the usual practices were at the health services, in which the specimens got sent to the various laboratories. At Health Service A, there was a 2-step process where they would first look for flu A and B and RSV, and then depending on those results, they would run another assay. At Health Service B, they just ran a single assay looking for everything. I should add at this point that before we combined the results, we did do a sensitivity analysis between the health services to see if there wasn't anything that was glaring, and there was not. In total, we ended up with 156 swabs. They were taken from residents who had typical comorbidities of people who are living in aged care homes. And again, most went to the Health Service 1, which is actually Health Service A. And we had the median range to results was 1 day. So that was, I only collected the time to results on the basis of days, not on hours. So a swab that was taken on 1 day, median time to result would have been reported in the resident's record the next day. So the results, about 45% came up with a virus. We had no bacteria identified in any of the results. And interestingly enough, how actually unique just having these PCR results actually are. Epidemiological work that's been done in respiratory tract infections in residents of aged care homes, almost without exception, has been done in residents after they've been transferred to hospital. I've yet to find a study where they've actually looked at residents who have been treated within the aged care homes themselves by nurses and general practitioners. And of our residents, we did have 94%, that was the case. We did have a small number who were transferred to hospital or who were placed on palliative care plans. The other thing is looking at other investigations. In most cases, other investigations were not performed. So there was 3 where there was sputum taken, 6 chest x-rays, some blood cultures, but really not, and there was in fact only 1 other investigation was positive, suggesting that there was a chest infection. So generally overall, there were quite a relatively well population, and that not many of them had to be transferred to hospital, and most of them, overwhelmingly, the number recovered. Having said all that, there was 156 swabs, and in total we ended up with 105 antimicrobial courses. All the antivirals that were prescribed was also tamivir, which I will discuss in a little bit. Oh, and the other thing that I will circle back to a little bit is that amoxicillin clavulanic acid, when I get to my conclusions and future directions where I think this work needs to go. So what we found is when we compared the virus detected to the virus detected results, episodes without any alteration, so that was a stop, start, or review of an antimicrobial after reporting of a result, that was more likely to happen in the virus detected results, which suggests that prescribers are responding. But overwhelmingly what we found was that it was episodes with an antiviral prescribed after a PCR result in response to an influenza positive result. So if the swab came back with influenza, the prescribers were responding. But if the swab was coming back with, say a rhinovirus, they weren't discontinuing any antibiotics as in antibacterials. The other, I guess, significant results we have, which I guess can be explained clinically, which really it shows that when the virus is, so antibiotic days of therapy for episodes not meeting the McGeer criteria, so these are the potentially inappropriate antibiotic days of therapy. So the signs and symptoms of the infection in the residents don't meet the criteria for lower respiratory tract infection. And what we found was in virus detected in the virus detected swabs, you were more likely to get inappropriate antibiotics, which makes sense clinically because they're the ones who are more likely to have the upper respiratory tract infections. So at a conclusion, respiratory viruses are common in aged care homes, and that most common change was that in the initiation of an antiviral in response to a positive flu result. The antibiotic discontinuation after the identification of a virus was not common, but also respiratory PCR are also useful to other purposes. I didn't display it here, but we did do a breakdown of infection prevention and control initiation, and you do find that there was a greater number of episodes had at least one infection prevention or control measure initiated in the virus positive episodes. So lastly, I will touch on this briefly, and these were my qualitative study that I performed looking at antimicrobial use near the end of life in aged care homes. So these are residents where there is a possibility that they are going to die. If it's family, I'll go GP. If it's GP, I'll go family. I'll use any side entrance I can to get in, and there's nothing wrong with that because I feel like I'm the resident advocate. And this is the aged care nurse. Just a little bit of background. Not everyone in an aged care home is at the end of life. However, up to 90, I believe it's 94% of separations from aged care homes, last separations from aged care home is due to death. So death is quite common in an aged care home. And in addition to that, antimicrobial use increases, especially in the last month of life before a resident dies. And so we wanted to look at what are the issues surrounding that, because in some prior work, it was identified this issue of advanced care planning, of family pressure around, especially when someone is towards the end of life. So we set out to undertake some interviews with health professionals and with residents to investigate the potential opportunity for this, because it's sort of like, I guess turning up the risk is what I've been thinking about in these situations. So the first paper that came out of this, the first of the interviews, really looks at, I guess, how these decisions get made within the aged care setting, and really investigate the potential opportunity for the aged care home nurses, because that was one of the things that came up very early on in doing the interviews. These sets of interviews were coded using behavior change frameworks, if we wanted to see how we could change the behavior around antibiotic prescribing towards the end of life, and also grounded theory. So nurses are influential in these decisions towards the end of the life because of their leadership in advanced care planning. It is often the case that it is the aged care home nurses that are sitting down with the residents and the family writing the advanced care plan. Even in the case of statutory advanced care plans that actually need to be signed by the medical doctor, it varies from place to place and from GP to GP how much of their involvement is in that advanced care plan, but overwhelmingly that gets presented to the family or the residents when they enter into aged care, and it's often the paperwork that actually comes from the aged care homes themselves. Nurses are also key in this care coordination and care provision in the environment to stopgap in visiting medical resources. So again, if there is a decision that needs to be made when you're at the end of life surrounding an antimicrobial, you would be very lucky if it is your primary GP who is making that for you. More often than not, it's going to be a locum doctor who makes that decision. Nurses also have the social influence during these critical conversations near the end of life, which can influence the decision-making, and past negative social interactions within the care environment can cause nurses to make fear-based decisions. So they really want you to have an antibiotic, not necessarily because you fit any sort of criteria, but because I'm afraid you're going to die on my watch. I'm afraid that there's going to be a complaint. So really when we look at those particular, like how those decisions get made, it's within the advanced care planning and the care coordination and delivery are important opportunities for the nurses to engage in antimicrobial activity or AMS activities towards the end of life. In addition to that, we were able to use those behavior change frameworks and then map those onto what is known as the behavior change wheel, which is done by Susan Mitchie and Jane Crane, to look at actual interventions that could possibly work for this particular cohort of residents. And what we found was that nurses will they will make decisions for antimicrobials with, you know, the best interests of the resident in mind, as in they, you know, will want to provide care for the resident, and those nurses who also undertake AMS activities, because there are places where AMS is on the agenda in aged care homes. They will do that as well with the best interests of the residents in mind. When the families become involved, they often only look at the issue with one side. So they will ask for an antibiotic, you know, to appease the family, but they don't consider those AMS, you know, the idea that an antibiotic could actually be causing harm here when dealing with the family. So we really need to make sure that that reassurance to family in any sort of AMS activity in this area is paramount. So you have to understand how to incorporate the families into this area. And again, education, training, and these enablement activities to improve the recognition and communication about appropriate end-of-life care are required. I hypothesize that getting this into nursing protocols could motivate and enable, make it part of the nurse's job. And then also this idea around accreditation standards are really important. The quote is, if it's not for accreditation, it doesn't matter in aged care. That was the best quote that came out of the interviews, I thought. And I guess we're lucky as well because the accreditation standards have changed or did change as of July 1st of this year. And there is appropriate antibiotic use that's now being incorporated into those standards. But I think it is going to take time. Conclusion and future directions. I think the way to go with this is actually, and it was interesting what Kaz said a couple of minutes ago about nudges. And I think the issue here, or one of the main things that can be done, is this addressing excessive, overly cautious, and fear-based antimicrobial prescribing habits that are not supported in evidence. So in all my projects, you saw it. So you saw it with the excessive daily doses of cefalexin, with the prescribing of augmentin instead of amoxicillin for the respiratory tract infections, and then with the nurses themselves saying that there is a lot of fear in aged care, and we do make antimicrobial prescribing decisions based on fear. And I think things like that actually address the habits is the way to go with this, as well as making sure that you are addressing the family confidence in resident well-being. There is some, when I started this out, I had difficulty getting traction in aged care homes. As I've continued on over the last 3.5 years, it is more and more. Whether or not that has to do with the change in accreditations, I'm not sure. But probably one of the best stories I have, which could highlight this, was I was speaking at the Australian Association of Gerontology conference last November. And I gave the talk and I highlighted the augmentin in our swabbing project. And I spoke after a GP, and a GP came up and sat down beside me at the end of my talk, and started to give the pushback about, they're clinically unwell, you have to be very careful, and which is what you normally get when you talk in this space. But then he said to me, but I would never prescribe augmentin as a first-line antibiotic to the residents that I look after in aged care. That's ridiculous. Why wouldn't they prescribe amoxicillin first? And I think the difference between him and perhaps some of the GPs which appeared in my study was just based on a habit, that he developed this habit that he would always prescribe the first line amoxicillin, versus for some reason the GPs which appeared in my study, the first line that they would always prescribe would be the augmentin, because really when you look at the clinical profile of people in my study, they weren't that unwell really as a whole. And I think that's the place to go, is with those habits and with those nudges going forward. I'm conscious of time. I have a lot of people to thank, including a lot of people in this room. Special thank you to my supervisors, David Kong, Ron Stewart, Carolyn Marshall, Deborah Friedman, and Kirsty Busing, as well as I've had Arjun, Nolene, and Fiona as NCAS collaborators in some of my studies. So thank you all.
It's really come together beautifully, hasn't it?
It does. It tells us. I can see the story now. Like it's hard to. It just really in the last few months, as I've had to sit down and write it and think about the conclusions and the future directions, like what it actually tells you, and you can see the story in it about this sort of fear-based prescribing and choosing one thing at a habit. And we don't have, with the ACNAB's UTI prescribing, we don't have the reason why they were doing that, like why they were prescribing 3 times daily or 4 times daily doses. But you can imagine that cefalexin's also recommended for other things, skin infections and whatnot. You can imagine the GP sitting there and just going, yeah.
Because you didn't talk about the excessive use of topical creams,
yeah,
which I think is a de facto the fear of skin tears and ulcers and everything else. And it's like, well, get the cream and antifungal cream, not just a moisturizer. So
yeah.
I think it is a de facto signal.
Yeah. So, and I also think there's something inherent about somebody being vulnerable in aged care. So again, because I've been doing my literature review, going through it, there was some work that was done this year when they compared older people who were living in the community with, you know, similar demographics and similar medical conditions to somebody who is living in an aged care home. The person who was living in an aged care home was 2 times more likely to be prescribed an antimicrobial for the same, you know, medical condition and the same signs and symptoms. But there's something, you know, inherent, I think, about living in an aged care home, which also promotes that fear. And also going around talking to GPs. I remember there was one GP I went and talked to, and I said something about, oh, fear, and he went, oh, that's it in aged care all the way. Like, there's a lot of guilt and fear and all wrapped up into it.
So if we think about improving outcomes or improving prescribing through structural measures and process measures.
Yeah.
It seems as though there's not enough structural measures in place in terms of medical on-site support, experienced nurses, clinical pathways for the common things, proper use of medicines, pharmacists, engagement with community pharmacists. You know, if you had a finite bucket of money to give aged care, where would you be driving your investment?
Oh yeah, so she asked me if I had a finite bucket of money to put into aged care, where would I put it? Yeah, for antimicrobial use. One of the things that I asked, and it's a difficult thing because you also get pushback in this space when you start talking about nurses and empowering the nurses in aged care. You get pushback from the GPs saying, like, why have you just skipped over us in doing this? So that's a lot of the pushback that we got with the swabbing. And the thing is that I think people within aged care, when you talk to the nurses, I got the idea that they did want more medical support. There's lots of homes that are now transitioning or trying to transition into like a team-based medical care, which is a tricky thing because under the Aged Care Act, when you enter into an aged care home, you're of course allowed to keep your GP, which, you know, there's wonderful, great reasons why that's so, but it does make the medical care into the home, it can make it very ad hoc. And it can mean that your medical care is just being, you know, fulfilled in the stopgap way after hours by locums. If I had an infinite bucket of money, I'd put a GP in every aged care home that there is, but I don't think that that's going to happen. And so then I think that if I would, you know, empower the nurses to do it because they're going to be there, and there's some fantastic aged care nurses, and you just need to make it part of their role.
Well, we've demonstrated pretty clearly in the sepsis pathway work that the nurses really are the drivers of the clinical pathway.
Yeah.
Because they make it easy for the doctors. And once the doctors recognise, oh, actually, all the tests have been done and this has been excluded, and the odds of this, then, oh, I can easily make that decision. Yeah. So I think moving towards strong clinical pathways is really key.
Yeah, strong clinical pathways, enable the nurses to do it, make it part of their job, part of their role, make them understand that improves the resident care, give them tools to engage with the family in an effective way, to, you know, explain to the family that this is actually the best care we can be giving your mother or father. It's not, you know, this is actually the best thing for them. I think that needs to be driven. And so I think from a realistic perspective, that would be the way to go.
There's the outcome, just your PCR testing study was an early pilot study, but at the same time, it's interesting that you know, one of the things that people say is diagnostic uncertainty contributes to unnecessary antibiotic use. But even in response to virus detection in the study, there was very little discontinuation.
Yes.
So I think that's an interesting finding.
Yeah, it's not, so the PCR study, it's not dissimilar to what they actually have found in acute care, is that there needs to be something else in addition. And in acute care, it's usually an AMS team or an AMS recommendation that you discontinue this. And how you would envision that in an aged care home, again, becomes incredibly difficult. But if there could be some sort of additional recommendation that was fed back to them to say, if they're clinically well enough, this shows that they have rhinovirus, But again, all that, again, in aged care, it can be extremely ad hoc because some aged care still have paper records. So a lab wouldn't even ever know what that person was on, right? So they would just get the swab and that would be the end of it. Yeah.
I wonder whether the argument, did you get any interview responses back from people after this study? Because I could see the standard argument would be, well, this is just in case of secondary infection, so we'll continue the antibiotics because
So maybe not surprising, but in talking to the homes, the nurses loved the swabbing. They loved the swabbing because they could take the initiative and get it done right away. What you got back from the GPs after the swabbing was, oh, well, you know, I didn't really see it until, you know, 6 days later and that kind of thing. Like there wasn't sort of the, like, close the loop in that regards, if that makes sense. And so co-infection with co-bacterial, co-viral infection is an issue. It does happen. But again, I think PSD has wrote some great line in one of my papers about, you know, if they are actually clinically well, and you do have the evidence that this is what it is. And I should also say, like the people in my study, I think there was only 21% or something of those residents actually had signs and symptoms of lower respiratory tract infection. So again, with that, 155 courses of antimicrobials for 160 episodes of respiratory tract infection, 80% of those residents had signs and symptoms of upper respiratory tract infection. So you do have to look at the clinical picture. But there's always ways I've learned to not do AMS, right? Like there's always ways that you can tell yourself that, you know, my resident is different, my resident is special, you don't understand my home. I've heard it a lot over the last 3 years, but it's just, I guess, changing their mind.
Thank you, Leslie.
Thank you, everyone, and see you at the next meeting.